Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, IIT Roorkee. We are doing the course titled Health, Humanities and Disability, and under this caption, we are discussing role of humanities in medicine. Well, in the field of medical humanities, gender differences manifest through distinct educational outcomes, career motivations, and systemic biases. While women often enter the field driven by altruistic and person oriented reason, men are frequently motivated by financial prestige and technical issues. These differences extend to how medical students develop empathy and experience mental health during their training. Empathy development and decline. And under this topic, we may discuss research which indicates significant variations in how male and female medical students engage with humanistic aspects of care. And the first is empathy levels. Women consistently score higher on empathy scales, particularly in affective empathy, that is emotional sharing. While no significant gender difference is typically found in cognitive empathy, intellectual perspective taking. Response to curriculum. Extensive preclinical medical humanities programs have been associated with a decline in empathy among male students during their clinical years, whereas female students show no such decline regardless of the program type. Empathy styles. Male students often adopt a practical, task oriented form of empathy focused on problem solving, while female students tend towards relational empathy, prioritizing emotional connection. So, career and specialty choices and gender roles significantly influence the type of medical careers and specialties students pursue. The first is specialty preferences. Women are more likely to choose communal specialties like family medicine, pediatrics, and primary care, which emphasize long term patient relationship. Men often prefer high prestige, technically demanding fields such as orthopedic surgery or cardiology. Motivating factors for female students, work life balance and lower workloads are primarily drivers. In contrast, male students often cite intellectual stimulation and expected salary as their top priorities. If we talk of systemic bias and mental health, well, this talks about gender disparities in medical humanity, also highlight deep-seated issues within the medical institution. Mental health. Female medical students report significantly higher level of depression, exhaustion, and perceived study demands compared to their male peers. Second is clinical communication. Bias is often reflected in how physicians document patient care. Text analysis of over 1.8 million records shows that physicians focus more on the emotions of female patients, sometimes pathologizing them as hysterical, while focusing on scientific and bodily diagnosis for men. Third is academic representation. Despite nearly equal enrollment rates, women remain underrepresented in leadership, holding only 15% of medical school dean position. Now, the point is that what is the feminist contribution to the field? So, the emergence of feminist medical humanities has been crucial in challenging the androcentric history of medicine, which historically used the male body as the default for research. Feminist scholarship has helped to identify gender bias in medical textbooks where male genitalia may be covered extensively while female organs are neglected. Expose the pathologization of female behavior, such as historically labeling women's physical symptoms as hysteria or emotional distress. Gender bias in medicine is a pervasive systemic issue that significantly distorts the quality of healthcare for women, men, and gender diverse individuals. While it most severely affects women who frequently experience symptoms, dismissal, and delayed diagnosis, it also negatively impacts men by discouraging help seeking due to rigid masculinity norms. So, bias in diagnosis and treatment shows stereotypes about how genders experience and report symptoms often lead to differential care. Some important ways these biases manifest are: first, the hysteria narrative. Doctors are more likely to view women's physical symptoms as emotional or psychological, while men with similar symptoms are seen as brave or stoic. This disparity, often called psycholization, results in women being 2.5 times more likely than men to be referred to mental health services when presenting with physical symptoms like fatigue or chronic pain. Second is pain management. Women are often prescribed sedatives or antidepressant for physical pain, whereas men are more likely to receive adequate pain medication. Third is cardiology. Women are 50% more likely to be misdiagnosed with a heart attack because diagnostic criteria were historically based on male classic symptoms. Women's atypical symptoms like nausea or fatigue are often missed. Fourth is underdiagnosis in men. Conditions stereotyped as feminine, such as depression or osteoporosis, frequently go undiagnosed in men because providers do not expect them to manifest. Now, the gender data gap in research, very important aspect in health humanities. For decades, medical research was conducted almost exclusively on male subjects, treating women as a smaller men, and the first exclusion from trial. Until 1993, women of childbearing age were often excluded from clinical trials to avoid potential fatal risk, leaving a lack of data on how drugs affect female biology. Then, laboratory bias. Even in early stage research, scientists often use only male cell lines or male animals, assuming female hormonal functional would skew results. Adverse outcomes. This lack of data means 8 out of 10 prescription drug removed from the market for safety reason posed greater health risk, specifically for women. If we talk of intersectionality and compounded bias, then gender bias rarely exists in isolation and is often intensified by other social factors. Racial intersection. Black women experience significantly higher maternal mortality rate, 3 to 4 times higher than white women, partly due to the persistent false stereotype that they have a higher pain tolerance. LGBTQ plus healthcare, transgender and non binary individuals face high rates of discrimination and denial of care. 50% of trans patients report having to teach their own doctors how to provide appropriate medical care. If we talk of impact on healthcare workforce, bias extends to medical professional, creating a cure versus care hierarchy. Leadership gap. Although women make up 70% of global healthcare workers, they hold only 15 to 20% of senior leadership or medical school dean position. Professional devaluation, specialities that are female dominated, such as primary care and pediatrics, are often less valued and lower paid than male dominated technical fields like surgery. So, how to counteract bias as a patient? Well, asking the direct questions. What else could these symptoms suggest? Or would you recommend this approach if a different gender had these symptoms? Second is request documentation. If a doctor refuses a test you requested, ask them to note the refusal in your chart. Third, seek second opinions. Look for specialists or providers with a specific training in gender medicine. So, the historical roots of hysteria. So, the term originates from the Greek word hystera, that is womb. For centuries, medical authorities believed a wandering womb caused everything from anxiety to fainting. While hysteria was removed from DSM in 1980, the underlying bias persists. First, the Yantel syndrome. Research shows women often receive less aggressive treatment than men until they prove they are as sick as their male counterpart. The emotional discount. Doctors are statistically more likely to use description like anxious, sensitive, or dramatic in female patient charts, which signals to future providers that the patients may be an unreliable narrator of their own. Then comes consequences of the brave versus emotional binary. Women suffering from a medical illness and expressing their pain are called emotional, and their pain is undermined. On the other hand, men suffering from the same illness and not expressing their pain due to societal expectation of stoicism and quiet endurance are called as brave, and their silence regarding the illness and pain is encouraged. The bias creates a double edged sword that harms both genders. For women, over medicalization of emotion, physical conditions like endometriosis, spots, and autoimmune diseases, which affect women at higher rates, take an average of 7 to 11 years to diagnose because early symptoms are dismissed as stress related. For men, under medicalization of emotion, the stoic stereotype makes doctor less likely to screen men for depression or anxiety. Consequently, men are less likely to seek help for mental health, contributing to higher suicide rates despite lower diagnosis rates. Modern examples of prejudice in clinical care. So, ER wait time. Women wait an average of 16 minutes longer than men to receive pain medication for acute abdominal pain. Then, cardiac event. When women report chest pain, they are frequently told they are having a panic attack, while men are immediately screened for heart disease. In health humanities, cardiac events are analyzed not just as biological malfunctions but as narrative failure, where systematic bias, gendered linguistics, and historical male as norm defaults collide. The field examines how heart disease, the leading killer of women globally, remains socially constructed as man's disease, leading to deadly delays in care and misdiagnosis. The male default in medical research, health humanities scholars critique the historical androcentrism of cardiology, where the male body has been the universal standard for decades. Standardized symptoms, the classic heart attack, crushing chest pain radiating down the left arm, is actually the male typical presentation. Marginalized realities, women's symptoms, nausea, extreme fatigue, jaw pain, and breathlessness were historically labeled a typical a linguistic choice that humanities scholars argues implicitly frames female experiences as deviant or less valid. Clinical trials. Until relatively recently, women were excluded from major cardiovascular trials due to concern over hormonal fluctuations, leaving a massive gender data gap in evidence based guidelines. Narrative bias and psychologization. The field of narrative medicine highlights how the stories women tell about their heart health are often read differently by providers. Emotional versus physical. Women are significantly more likely to have their cardiac symptoms misdiagnosed as anxiety, stress, and gastrointestinal issues. The Stoicism paradox. While men's stoic silence is often praised, women's detailed description of discomfort may lead physicians to pathologize them as anxious or hysterical. Wait times. Humanities informed data shows women wait an average of 11 to 16 minutes longer in emergency departments for cardiac evaluation than men with identical complaints. If we talk of socio-cultural barriers to care, health humanity also explores the lived experience of cardiac events, looking at the external pressures that influence health outcome. The caregiver delay. Women often arrive at hospitals up to 12 hours later than men during an active heart attack. Scholars link this Two, internalized gender roles where women prioritize family stability and caregiving over their own emergency needs. Rehabilitation gaps. Women are less likely to be referred to cardiac rehabilitation programs. Humanities researchers point to structural barriers like the lack of childcare, lower financial autonomy, and programs designed with male preferences in mind. Intersectional insight. And under this, we may discuss bias in cardiology, which is compounded by race and socioeconomic status. For example, Black women face higher maternal mortality and cardiac risk, but are even less likely to have their symptoms taken seriously due to overlapping racial and gender stereotypes. If we talk of strategies for institutional change, then first come the narrative training. So, teaching clinicians to recognize their own implicit biases through the study of patient stories. Then come visual representation, redesigning medical education tools to include female specific diagnostic images and case studies. Reframing language, moving away from the term atypical to emphasize that these are standard gender specific presentations. In health humanities, intersectionality is a critical framework used to move beyond single axis analysis like gender alone to understand how overlapping social identities such as race, class, and disability interact with systematic power structures to shape health outcomes. It redefines cardiac events not just as clinical occurrences but as complex narrative failures influenced by multiple compounding layers of bias. So, intersectionality reveals that marginalized groups experience cardiovascular disease through a multiplier effect of burdens. The race gender hierarchy. Research often ranks cardiovascular health outcomes by intersectional status, with white women typically achieving the highest CVH scores, followed by white men, black men, and finally, black women at the bottom. Heart transplant disparity. On transplant waiting list, Black women and men have significantly lower odds of receiving a heart transplant compared to their white counterpart of the same gender. Transgender and minority status. Black and Hispanic transgender individuals face significantly higher rates of conditions like peripheral vascular disease and congestive heart failure than white cisgender peers, and access directly attributable to the intersection of gender, race, and ethnicity. With this, I conclude this lecture. We shall discuss next time with a new topic under the health humanities and disability. Till then, thank you.